Thank you.
8 p.m. Should we start? Sir, should we start, sir? It's 8 p.m.
Yeah, I think you can start.
19 members are there.
Doesn't matter. Start.
Yes, sir.
People must be busy watching YouTubes and TV channels about the ceasefire. So
Yes, sir.
I wish there is a ceasefire in our WhatsApp groups too.
Yes.
Okay, please.
So, good evening, all, and welcome to the inaugural webinar of Association of Adolescent Surgery and Translational Care. In this time of sorrow and remembrance, our hearts go out to the victims of the Pahalgam also, and for their families. May those we left us rest in peace, and those may their loved ones find strength in the unity and compassion of all us. We all also want to wish our best wishes to the Indian armies, whose brave heart, courage, dedication, and sacrifice inspires the whole of the nations. May you always be strong, safe, and victorious. Jai Hind. And now I wish to invite our chairperson of this section, Professor Subhasish Saha sir, to start the further proceedings. Sir, please.
Yeah, thank you, Dr. Sunita. Hello, everyone. Good evening. So this is the inaugural program of this association chapter. So this was I would just like to take you briefly through the journey. In 2023 October, the Professor Yogesh Sarin first suggested that whether we could, those of us who are interested, if we could single out this space where we should work more, that is the adolescent surgery. So basically, some of us, we came together, 18 of us, and we formed this chapter. So not much has been done since then, but we talked to each other and we have formed this basic nucleus of this organization. Registration is yet to be completed. And the name as of today is Indian Association of Adolescent Surgery and Transitional Care. But it's possible that during registration, because of the rules and technicalities, there might be a little change in the name. So basically, what's the motto of this another group? Because already we have groups like PACI, we have groups like SPU, we have a research group, thoracic group. But all said and done, what we see is that most of us, many of us, not most of us, many of us who are trained, especially in 5 years course and all that, we deal mostly with infants, neonates, and children. Now, as soon as a child of a little older age group, peri-adolescent age group, say 14, 15, 12, even most of the government hospitals, many of the government hospitals, they don't admit, the pediatric surgery departments, they don't admit children beyond 12 years. So what happens to this gray zone, that's 12 to 18 years? So where there is no pediatric surgery department entertaining this group of children, they go to the adult surgeons. And often it happens that they are in a fix. Like an adult surgeon is not well versed what to do with a child with posterior urethral valve. He is not well versed how to manage an anorectal malformation, how to manage an Hirschsprung's disease, or maybe similar other deformities, maybe a disorder of sex differentiation. Now, all these areas need expertise and they need actually pediatric surgical input. So these children get left out as they approach their adolescence, and proper transitional care doesn't happen. That's one part of the story. The second part of the story is we often discuss in our WhatsApp group and amongst ourselves of the shrinking landscape of pediatric surgery and the organ-specific people taking over our work. Now, there are a lot of issues, but one of the thing is we should also, it's time to highlight that the adolescent surgical issues can be best taken care of by the pediatric surgeons, and it has to be declared with unambiguous tone, in an unambiguous tone. So besides this, what we have seen is especially many of us who also operate on adolescent. Like in my hospital, the cutoff in my department is up to 18 years. So we deal with children up to 18 years, any emergency, non-emergency. And what we have seen is there is a difference in the method of how you approach these patients. A lap chole in a 5-year child and in a 14-year child is absolutely different. And there are challenges. There are hormonal issues. Gynecologists need to chip in. So what we have tried to do is we have made a team where we have our colleagues, like a gynecologist colleague, a urologist colleague, who is eager to take on these the continued care of these children, especially in tumors. Also, the same thing happens. So it's always good that we organize this adolescent surgery is organized by the care of these children is organized by the pediatric surgeons per se. So with this thought, and it includes everything. It includes thoracic, it includes lap, it includes minimal invasive tumors, all these chapters taken together. And it requires something else. It requires input from the adult surgeons as well. Like a hernia, suppose a big hernia in a 14-year child needs a different management. It's not just ligating the deep ring. So we need to train ourselves, and this interaction always opens up an exchange of knowledge. So that's the basic premises. Without wasting much time, I would like to invite the chairpersons for today's meeting, Professor Yogesh Sarin and Professor Soumitra Biswas. Now, Professor Yogesh Sarin is the director of the Department of Pediatric Surgery, Lady Hardinge Medical College at the present. He had been in MAMC for a long time. We all know his contribution, and for such a illustrious career and for such a long time, for more than 30 years, he is into pediatric surgery, into teaching, into publications, and he's an editor of so many journals. So it's a great thing, and he's our main patron and the spirit behind developing this chapter. So I would like to welcome Professor Sarin to today's meeting as chairperson. We have Professor Soumitra Biswas with us. He is one of the most academic-oriented senior surgeons in West Bengal. He is the current president, and he has been the head of the department of the main teaching hospital of MCH Training Institute in West Bengal. That's the NRS Medical College. And he is an inspiration to many of us. And any hour of the day, if we have any issues, he always lends us our helping hand. And it's also very nice, and we are really fortunate to have him as a chairperson for today's meeting. So I'd like to, at this point, hand over the program to the chairpersons. And please go ahead with today's meeting. Thank you.
Subhashish, I need to make a correction. Actually, this chapter was accepted by both executive and GBM as early as 2021. It kind of got delayed, and then they said we'll kind of finalize it in 2022, and that was the time when I was president of IAPS. And from there on, we have been slowly working on it. And now, maybe in a few months, we'll be working full. So basically, what is the idea about this whole chapter? Already Subhashish has mentioned a lot, but I will tell you a few more things. One is, it's got two parts really. One is adolescent surgery, because many departments do not take care of patients between 12 to 18. I mean, in my long career in one MMC and before that in CMC Ludhiana, the patients were admitted only up to 12 years of age. So I did not see a patient of renal cell carcinoma, although I saw many of Wilms tumor. Accordingly, so there are a lot of things that we miss out, and I will give some examples. One was that I used to do a lot of early surgery vaginoplasties for MRKI children. And two of them, about 2-3 years back, they eventually, which were earlier diagnosed not to have uterus, or it was very hypoplastic uterus, that turned out to be a normal uterus, but they did not have this connection. We never even attempted to make it because we did not know the uterus was there. And they will have hematometria. So after that, I did attempt once to attach that vagina to I removed a core of the uterus and did it, but it didn't work for more than 2 months. And it was impossible for me to get these two children treated. Now, 16 years, I was begging to gynecologists, both in this institution of Lady Harding as well as in AIMS New Delhi. Things were very difficult for the family. There are other incidents also. A child whom I had operated 18 hours for a gunshot injury into the anal canal, and which had blasted all the organs in the perineum. Eventually, this boy had neurogenic bladder, then slowly went into CKD and needed renal transplant program. And initially, the parents were very anxious to have it. I mean, they were very keen. But when the tragedy goes into chronicity over years, then that thing wanes off. It wanes off. So parents were not keen to have any renal transplant done for him at the age of, say, 18, 19. And I remember going to his funeral and crying and howling there, like as if somebody from my own family has died. There are other examples. Somebody who had bladder augmentation at the age of, say, 12 years in my early career is now 40 years and ends up having bladder stones, and no adult surgeon or urologist wants to touch it. So he comes to get to my department, and the sister in charges and the staff nurses, both in the ward and the OT, object that this patient should not be in this ward. This is for the children. So that there, wherein we started thinking of transitional care and getting trained from adult surgeons and training them as well. So this is the second aspect, that is the transitional care, and it's very important to provide safe, effective, and developmentally appropriate transition process and transfer a proper handover from children's services to adult services for all young people who long-term conditions require an ongoing care. We all know that adolescence and the young adulthood, I mean, some define as 21 till 21 years of age, some define as 25 years of age. It's a time of physical, psychological, educational, and social change. They have a lot of issues that need to be dealt, which we are not really competent to deal with. So if you have a high quality, safe and individualized and a consistent transitional care that is available, that would be fantastic. And so when we had already started talking about in 21, as I said, sometime later in late 23, the pediatricians got activated on this. They always had a adolescent care chapter, which is very, very active. So taking cue from them, the Government of India, Ministry of Health, Family Welfare, they made a committee of pediatricians, and now you have documents, you have websites of government that kind of mentions transitional care, and they believe that this can be executive at most of the new AIMS and the government hospitals, eventually slowly picking it up. So basically, now we need to kind of make two changes. One is that all departments, including government hospitals, government hospitals take the excuse that if we add children from 12 to 18 years, then we kind of need more infrastructure, more HR and all that, which are not available in the government sector. But that has to be created. On one hand, you don't want your adult organ-specific surgeons to take away your work. At the same time, you're actually willfully giving 6 years of population to them to do. And we also need to equip ourselves to do all those things that probably get missed out in the early pledge, and we then pick it up. I did some data collection for Lady Harding for the last 4 years in our setup, and that's kind of not mentioned in literature. We mainly had patients of appendicitis, typhoid peritonitis, Cox abdomen in a very, very big way, and very minuscule kind of were those who kind of needed some kind of gynecological procedure, or those patients where somebody had done a pull through for the bowel but had left the urogenital sinus as such, and things like that. So I'm very proud that other than PESI, which started in sometime in 2001, all other chapters were formed when I was secretary of IAPS in 2006, 7 maybe, 2006 mainly. And now one more chapter is coming up. So we all on our letterheads could write neonatal, pediatric, and adolescent surgeons. And we must create a lobby of people within our own institutions which are equally adept to kind of take them over for their transitional care for the rest coming 10 years or so. With these words, I would invite our President IAPS, Dr. Biswas, to say a few words. Dada.
Thank you, Yogesh. At the outset, I pray for Professor Ravi Kumar's speedy recovery. In the chair, I am replacing him for tonight. I congratulate all of you, those who are taking the initiative for this very needed chapter, what I think we needed chapter, because beyond 12 years, I was in government service. So beyond 12 years, we are not able to do anything for these children. We have to take half-hearted efforts from our senior colleagues. So this chapter is very much needed, and I congratulate Yogesh to initiate the spark for formation of this chapter. Like children, adolescents are not also mini adults. These teenage persons have so many issues, psychic issues, social issues, along with particularly those with suffering from congenital abnormalities, and we somehow don't make them perfect, but socially acceptable, like ectopia basis and other things, with lifelong problems inherent to our surgery. But as we must form this chapter, we must think that we alone with pediatric surgeon will not be able to cover all the issues. So this must be a more broader chapter, admitting other people also, like adult urologists, gynecologists, psychiatrists, social workers, all those things should be incorporated. And our rules must be somewhat flexible to have, and that is a subject of further discussion, who can be our members. But overall, we, the treating pediatric surgeon, should take the lead of the team. And probably it is not for the adolescent period up to 18 years, but he should be there till he is alive, because our patient will surpass us. We will not be able to follow up our all patients in their adulthood. With this few words, I invite the moderators to start the meeting. Thank you all.
Thank you, sir. So for today's session, our moderator are Professor Prema Menon ma'am, a senior professor from PGI Chandigarh, and Professor Shilpa Sharma ma'am from AIMS New Delhi. Please, ma'am, take over the webinar and introduce our speakers also.
Thank you. Thank you, Sunita. And welcome and good evening to everyone. It's my pleasure to introduce Professor Ramesh Santana Krishnan. We all know him very well, but still, I'll just say a few words. He's a highly qualified pediatric surgeon who established the Department of Pediatric Surgery in Bangalore, Indira Gandhi Institute of Child Health. He is highly qualified and he has experience. He has a special interest in minimal access surgery, but then he has conducted training courses in almost all fields of pediatric surgery. And he also has a very good experience now in private setup also, I think. So he has received several awards and orations, including Pesci Oration and the T. Dorairajan Award for the services he has rendered in pediatric surgery. So I welcome him and would request him to start his talk.
Thank you very much, Prema, for all your nice words, and I really appreciate it. Thank you. Sunita, am I audible and visible?
Yes, sir.
Yes.
Yes.
Yeah, I'll go ahead with it. See, transitional care in pediatric surgery is a topic which is very, very close to my heart. In fact, the NIDA started several years back when Dr. Vipul Upadhyaya visited our department and gave a talk on this. That's the time I realized that what we are doing as pediatric surgeons in handling children when they're young with us is fantastic. But what needs as a human being is to complete their lives. And when we need to complete their lives, we need to complete them in all the aspects. It's not just about the surgical aspects that we cover, but about the social, financial, personal, professional. I mean, there's much more. Our journey with our trust with the patient that we have doesn't end just with what we handle them. A successful hernia is okay. They don't need to come to us for life. But when the moment we do a Hirschsprungs or say anorectal malformation or Wilms, our concept, for that matter, even hypospadias, I think the moment we start treating them, our journey starts with them. It's going to be a long journey with lots of problems, issues, handling. It's not just about the surgical skills, but about the empathy and the sympathy and the understanding that we have with them. This is the one which talked about the transitional care, at least the seeds were sown into me. That's the time I started seriously thinking about it, looking around, and I thought I will do something phenomenally. That is the time when I realized there are a lot more people in the country who already have thought about this and already doing something. So I joined the bandwagon, and now we are happy. There are so many people talking about it. Still, it needs to reach a large number of people. That's the reason for which this talk, I put it about transitional care in pediatric surgery, the need, the current practices in the world, and suggested model in India. These are a list of patients whom I've operated about anywhere between 20 to 25 years earlier. The first child is about portal hypertension, operated about 25 years back, and now she is all right. She has now come back to show her son to me for something else. This is a child with extravascular bladder, had a lot of issues. Finally, we closed the bladder when we gave a metformin, and is a swimming champion now. There's a child with irritable bowel syndrome with Crohn's disease, operated, PU valves, and the like, hydrocephalus and cloaca and the like. They're all very happy because they came back to me, they told, I'm happy, I click photos. But there are a few points where I realized our inadequacies. For example, this is a child called Aniradha. Now she is no more a child, she is now 40 years old or 40, little plus than 40. She presented with basically extravascular bladder to my mentor, Dr. Srimurthy. 40 years back for extravascular, everything failed. Finally, he has done an Indian approach. She is on CAC, happy and moving around. She conquered the world by doing a CA without even her next people knowing it. That's why for public, she is called Sadhana, even though her name is Anuradha. She got married. But at every stage of a problem, she used to contact me, whether it's a gynec problem, whether it's dyspareunia, dysmenorrhea, low back pain, problem for hysterectomy. Every single time she used to contact me because we had developed an emotional bond. Right now she is in St. John's fighting for some other issues, other obstruction problems. So what I'm saying is there are so many things which we don't have a problem. We don't have a solution for the problem. Second is about a case in a point is about Satish. This is a child with a meningomyelocele with a long heart-tugging story about a mother not willing to have one more child because this fellow is incontinent, presented to me. I did some sort of CAC. After that he was so continent, he became normal life, got everything. A normal story where all of us would have been very happy presenting. Story doesn't end. 20 years back, he comes back to me and says, "Sir, now I want to marry." And when he wants to marry, he has a problem. He's got meningomyelocele, he's got a spine issues, he's got erectile issues, he's got urinary problems. I said, I can handle you with all the things about urology. I can talk to you about hydronephrosis, maybe renal failure, renal problems. But I said, sir, no problem is about now the sexual issues. I'm getting married. I need to satisfy my wife. That's the time I had a problem. So I had to take the help of andrologist and I had to just simply convey. What I'm saying is, these are, am I all right? Can I, Yogesh?
Yes, sir. Please.
Okay, I'll go ahead. Okay, what I'm talking about is, this is the tip of the iceberg. I can quote umpteen number of examples. I'm sure all the seniors here who have practiced for about 20, 30 years will tell about stories of their own. Like Yogesh had a lot of cases. I'm sure Ravindra Vora sir has, Ravi Kumar has got multitude of them. What I'm telling is, of the number of children that we operate, huge number, how many of them actually come to us at adolescence? Very few. And all that I've told is about only an example of those children who chose to come back. Their parents supported us, them, and they came back to us. Tell me how many of them did not even know that continence in a different form, like a Mitrofanoff or a Malone's, is possible for a child with an incontinence because of some urinary issues or an erectile malformation. For each child who presents to us at adolescence with a problem like this, there are at least about 100 of them who are languishing with a problem, shame, and an irreconcilable amount of guilt and give up in life. It is this that I would like to talk about transitional care. What exactly is a transitional care? Transitional care is a purposeful, planned process of transferring the health care of a child from a pediatric to an adult caregiver to ensure continuity of care. Please understand, this transition is very different from transfer. When we transfer, it means it's a one-off. There's a patient who has a medical problem in a surgical ward, a surgical problem in a medical ward. We simply call the other specialty, say, please transfer this for your continuing care, and we are not bothered much about except for a few days to find out of curiosity what happens. Transition is not that way, because the child has spent the entire childhood with us, and now they're going to be transitioning to an adult counterpart who may not know anything about this or may not have an emotional connect with the child, and still we have to give. It's like our, the daughter which we have brought up so much and we're giving it to them. It requires it. There's a pressing need for transitional care, like Yogesh said, both because many times when it comes to adolescence and adult, we understand that both the patient and caregiver are clueless and ill-equipped at least at many times. We have developed a personal bond and desperately want to help them. Because I got a child who operated for cloaca, has some major issues. Now she comes at about 24 years. She says, I'm getting married next month. I need to do something about her. I can't say it's not my concern, go away. Not possible. They are seeking solutions from us, which we, at least sometimes, simply don't have. Currently, of course, all of us, without exception as a pediatric surgeon, all seniors, we cope up with what we think is best. We call up somebody whom we know, who we think can deliver justice, do something and do something about it. But there is no structured transition care program to our adult counterparts. This is going to be an issue. In addition, we also have a lot of current day challenges because of the changing scenario. There are higher survival for all these conditions. For example, in my training time, the survival of a TOF was a miracle. And the survival of a diaphragmatic hernia was difficult. Now I get patients who have been operated so long back come to me with a fresh set of problems. Survival is much better in most of the conditions, because of which a lot of hidden morbidity is unraveled, which we never knew. For example, the child with extrophy, all we are talking about is about all type of repair, nothing works, you put augmentation, you put midrefrenum, it's all right. Now I have this girl who is now 45 years of age, who has problem of spine issues, back pain, has some dyspareunia, problems of catheterization, multiple problems of stones. How to handle it? Now she has got into renal failure. How to handle it? The problem is so much of morbidity which was never known has become unraveled. In addition, in the current age, the expectations of parents and children are enormous. I'm sure all of you will agree. This is a transition which has happened in the last 10-15 years, in which the expectations of parents are sky high. They say, I want my baby all right. I want my child all right. To be all right. That question of all right, who is going to decide? Children are no different. For example, they cannot accept even a small degree of a cosmetic disfigurement. For example, there are studies, multiple studies about, say, children with hypospadias, where we say they have done well. We are very happy. They are passing urine is in good stream, and we feel the cosmesis is acceptable. They feel they are not all right. They feel the genitals are ill-formed. They are not happy because they are getting a sexual, delayed sexual debut. They have a problem. So what I'm saying is expectations are different. In addition, worst thing is our social media and Google culture give rise to a lot of disinformation pandemic. I don't call it information pandemic. There are a lot of them. So what then are conditions where this chapter has to address? These are things. There are childhood ailments in adulthood. For example, adult presentation of congenital anomalies like a PUJO or VUR, etc., or ailments with an equivalent in childhood like an asthma, IBD, etc. These are no-brainers. It's okay because there are guidelines. There are people who can still do. A general surgeon or general physician can do. All they're required to do is just call us up. We can help them out. The problem is different. The ailments which started in childhood are needing care into their adulthood, like medical conditions like cystic fibrosis, diabetes, etc., are generic. All of us are very clear. Urology issues, neurogenic bladder, PUS, incontinence, etc., colorectal problems, anal malformations, hair sprungs. And what about gynec? We do vaginal reconstructions. What happens to them? So these are the list of conditions which I'll quickly go through. Continuing care into adulthood. That is, these are the cases which we have handled at childhood. We have to give it to our adults because we can't carry beyond. Because there are patients that say pupils have operated or something, they come to me with renal failure at adolescence. I need to transfer to them to adult care unit. I transfer to them. They are not happy about hydronephrosis, which is difficult to convince them this hydronephrosis is because of the gallbladder syndrome. It's not because of an obstruction. The child requires a renal therapy for CKD, and maybe it's a good transplant patient for transplant. Enroll them. They don't want because they handle the whole thing in a very different way. Posturethral valves. How many of us, please tell me, have come to us at adolescence say that we have problems? We do agree, literature says, but how many of our own patients? Extraphy bladder, urogenital sinus, DSDs, genital reconstructions. What about GIT and colorectal problems, anorectal malformation? We all know at least about 2/3 of patients do not have adequate continence. What do we do for them? We talk about melons, we talk about this, etc. But how many of them come to us for a productive adulthood? Hirschsprungs, Crohn's, corrosive strictures of esophagus. Yes, I had a patient who had a corrosive stricture for whom I had an esophageal substitution about 15 years back. Now he comes back to me saying that, sir, my upper end is stenosed. I have no wherewithal how to do it. I have to get somebody else to do it. It's an issue. What I'm saying is there are cases where we need somebody else to help us out and we need to help them out so that we take care of our center of excellence, that is our patients. Gynecology, like I said, vaginal anesthesia, atresia, where so happen. How many of them do get vaginal stenosis? For example, I had a child whom I have operated for cloaca. She is now continent, urinary, fecal, everything is fine. She has a vaginal outlet which is good enough to secrete the menstrual fluid. She said, I don't want a marriage, etc. Now she comes and gives me a marriage invitation. I said, have you got a vaginal check? Because the child, I remember, had a vaginal stenosis. She said, no, sir. I said, why don't you go now? Sir, my marriage is day after tomorrow. What do you tell? What I'm saying is there are so many patients on whom we operate at childhood thinking that is the best. What do you handle? I have patients of hydrocephalus operated at birth. They're done well for 22, 23, 24 years. Now they come back with block shunt or something. Meningomyelocele where they have lateral tethering, tumors with second, tumors, lymphomuscular malformations, facial and body deformities. Now because we operated a child when it was acceptable to the parents, now the child is not happy. What do we do? In addition, there are a lot of additional challenges in adolescence because of changing body, physiology, and of course, I think somebody referred to this earlier, is changing psychology. Children, when they come to teenage, are definitely having a rebellious attitude. They want to change the world. They think the world is theirs and they're not happy. They have got increasing body mass, which unmasks health issue. For example, a child with a borderline CKD can get into full-blown CKD at puberty because of an increasing body mass. Then they have pressure, peer pressure and social pressure. They need to look normal, they need to appear normal, they need to behave normal, and they have things which they're not happy about. On top of it, today there's so much of social media and information explosion and easy access to internet, because all the access is what is available on the net, which is simply Google and may not be reliable. There are going to be so many things which are not easily replicable in our country. In addition, with the widespread across the country, there is a susceptibility to alcohol and substance abuse to which these teenagers can get into if they're not happy about. The other side is our counterparts. They have their own clinical load, which is huge, successful, and lucrative. And they're simply clueless because there are changing concepts. I've got a lot of general surgeons who still remember pediatric surgery from the time they practiced. They feel that every newborn is going to die. They feel that every simple thing can be handled and everything else we're talking is about bakwas. They don't know about the change of concepts. They don't have any experience. It requires a lot of efforts to handle a child with, say, neurogenic bladder, feeding issues, etc. And it's very less rewarding. They don't understand the needs of the child. It's not just about the physical needs, it's about psychological needs, it's about the emotional needs. It needs to be a support which we have provided for so long, otherwise they won't be persisting with us. There's a lack of sensitivity and empathy because they feel the moment they do a vulgarization of poster, anything else is immaterial to them. So what is the scenario in the world? So when I'm talking about it so emotionally, let us also look at it about what is happening in the world. Across the world, whatever contacts I had, I've been speaking to them for the last several years. I've searched literature. Finally, it realized that it is finally individual based. Structured things for specific things are there for, say, spina bifida, oncology, and cystic fibrosis, etc. in the developed world, but nothing much in the developing world. In generic, that is specific about whatever we are talking about, are there in British Columbia, Vancouver, about On Track, that is taking responsibility for adolescent and adult care. There's something in Los Angeles talking about creating Healthy Futures Clinic, Nottingham, Melbourne, Dartmouth, etc. But what really struck me was much more relatable, because these things are more about Western world where the system is very different from what we have here. So when we talked about it, the paper which really made me take notice of the whole thing was about from Dr. Vipul Upadhyay. We're talking about transitioning pediatrics patients, which I thought is much more relatable to us than anything else. He talked about what is transitional care is a purposeful, planned procedure to address the medical, social, educational, vocational needs of adolescents and young adults with chronic physical and medical conditions as they move from child-centered to adult-oriented healthcare system. Please understand, when it comes to child-oriented and adult-oriented is different. When it's child-oriented, all the decisions are made by the parents. When it's adult-oriented, whole decision making is taken by the child or the patient himself. When he talks about central unit, he talks about a lifetime commitment and provide a long-term and very long-term care with easy communication, easy anticipation, and effective resolution of the problems. If this does not exist, he talks about saying it will need to be established and expected created a high standard of care. All of us, in the last whatever time that we've been alive, we know that this is simply not possible in India. For example, the procedure he talks about is once you define the transition process, the time, it starts about 2 years early, where the adult surgeon will partly be there and the pediatric surgeon is there, and 2 years over, and then there's a graduation, and then it is transition to adults where we participate less. This is easier said than done. I'll be very happy if this can be done. I wish it can be done. I wish I'm going to be proved wrong, but I'm not too sure. So the simple philosophy is that saying you identify a group of patients Identifying transitioning physician like us, who is the consultant who is responsible, get to a transition clinic where you're going to nurse practitioner, which is non-existent in India, psychologist, who is going to be very difficult to find out. Then it finally identifying about transition interested adult physician, and then there's a general practitioner to throw it with. Then we make them into something, and then we throw them into the real world. Then it talks about potential sources of obstacles, saying pediatric team not willing to let go. Adolescents and parents and other things don't see any advantage because they're so much used to that. Workload in adult services is very high. System issues indicate difficulty in seamless transfer of medical records, etc. And then it talks about a written policy about how to do it, etc., etc., etc. It's fantastic. I think it's a blueprint to follow. But unfortunately, in our country, knowing what we are, हम नहीं सुधरेंगे. If that is the case, that we need to do something more. So, in Indian milieu, as much as I could see, there's no structured referral system. There's no support system. We don't have nurse practitioners. We don't have pediatricians coming and helping us out, and or the office staff helping us. Government, as usual, across the country, across the parties, are apathetic. There's a lack of awareness because I think all over in the country, we have a system that we are overburdened. We are bothered about delivering justice to the patient that we have, and once treated, it's not our bother issue. I don't know how many of you have read When Breath Becomes Air by Paul Kalanidhi. If whoever has not read it, I think you should read it. That's the time that you realize that so much of human value is attached, which is missing sorely in our system. Obviously, the major culprit for this is clinical overload because of so many other issues. Let's not talk. Then there's a turf war between specialities because pediatric surgeons want to do, urologists want to do urology, adult gynecologists want to do, we want to do. But the point is, everybody wants to take the cream and not the scum, not the leftover. And here, as pediatric surgeons, like we are always committed, we are interested in doing the best to every single child. So here, we are left with a lot of things. And in the end, we as a pediatric surgeon, we are all in one. Sakalakala Vallaban, like they call in Tamil or Kannada. That is, we have to play the role of the counselor, we have to play the role of a parent, we have to role of the financial planner, the documentist, and what you call counselor, the clerk, and whatnot. So it is here that we need to do something about. As much as I visualize, the way forward will be at different levels. First level will be at individual or an institutional level, like all of us at our level. What we need to do is to learn lessons that we have learned so far. We need to spread awareness first amongst pediatric surgeons that there is a necessity for us to handle children with problems that we have already operated for. We need to ask the pediatricians to also chip in with their other issues. We need to identify adult counterparts who are interested. Because across this country, I found it difficult because when I have a problem with a gynec problem of an adolescent child, when I talk to most of the gynecologists I know personally well, they say, sorry sir, we don't know much. Last time in Karnataka State Conference, we organized a special talk for an adolescent gynecologist to come. And for she couldn't come, she sent somebody on her behalf. She talked about theory about everything. I said, Madam, I've got a patient, I have operated CAH, high vaginal insertion. I can't do anything. I don't know when to predict puberty. I don't want to come at hematometrocalpros. Tell me how to handle the child. She is clueless. What I'm saying is we need to identify adult counterparts who are interested in this. The general public also have to be told that there's going to be something because we care for the child. Somehow, the sensitivity of many people in the West is lacking. I think it's because we are overpopulated, maybe less sensitive, I don't know. But there's need to be a value put on every single child and every single child's quality of life. Apart from that, we need to sensitize the patient and caregiver. We need to identify and involve adult counterparts like I told. Develop a consensus because they have some other thing, we have to get it. We need to get everything documented and persist. At an association level, IAPS, I think I gave a talk in about 2 or 3 years back in Aurangabad, the national conference. I'm sure already Yogesh and other things are taken. Please understand, we are all but one. We are not playing politics here. Just like our Indo-Pak war, where all the people were together, all the IAPS people are here together. We need to have a written policy. We need to liaison with other associations so that we can identify people, say in Urology Association, Gynecology Association, General Surgery Association, Gastroenterology, at least identify people who are interested to be associated with us, not for photo op, not for publicity, but for real service. We need to spread awareness. And the third thing is very important about influence government for formulating policy and funding. It is here that I think Yogesh already touched upon early this evening that IAP is way ahead of us. They're doing it. I think we have no other choice except to catch their tail and go with them, so that whatever they do, let's at least try to put it. Because frankly, being 30 years in pediatric surgery, I find those people with influence does not do much, at least for the association. I'm sorry to say this, I may be castigated, but that's the truth. People with vision don't have power, people with power don't have vision. Obviously, I realize that the government hospital sector, being working in, I have put in my heart, soul and everything in a government sector hospital for about 30 years now. I retired, and now I realize it's difficult to get things beyond a level. Of course, it's a credit worthy that for all people of us who are doing in government sector to do things. But finally, when it comes to a real thing to do, sometimes it's a problem. At least we have much better freedom if we have got NGO support. In fact, that's what I'm aiming for now. Suggested Indian model, I also want at least a centralized team in individual cities, towns, involvement of a primary surgeon, because I realize that many of the our own colleagues, let me not name them, but all of them are difficult. They don't want to give up their case. They want to have a say. So best thing is, instead of them sending elsewhere, I said, please involve with us. You be involved on all the decision making. The primary surgeon gets the case and gets with the team. We need to have an involvement of a committed adult counterpart. Then we need to have a core team of non-medical personnel. I think Voras had talked a lot about it. I think Sumitra Baswas also spoke. We require office staff to maintain records. We need paramedical staff to counsel them. Most important, we're talking about counselors, because with the few numbers we manage, it's fine. When the numbers are going to be more, it's going to be. I'll wind up soon, madam. I'll wind up soon, sir. Then apart from counselors, we need to have legal support, because now there are adolescents, going to be adults, going to have. We need NGO support to take it. We need to have a documentation of all the previous documents so that we don't miss out anything. We need to have future plans also documented. Communication and consent in the current day is very important. Any change of plans have to be changed. Age of transition has to be defined as per the condition, not necessarily taking. For example, a child with a CH may require sooner, a child with renal failure may require later, but I think we need to identify transition may vary, but we need to have. Maybe the transition cannot be 5 years, maybe have to have 3 years. Most important, I feel, is that to identify patients who may need transition care and to sensitize them at each admission. For example, any child with anorectal malformation requires lifelong. PULs requires long. Neurogenic bladder, yes, they require. So what I'm saying is, talk to them, identify them, sensitize them at each admission, keep a separate register, make sure that you follow them up till at least they are adults. Inculcate the training or education and counseling into the training itself. Like, for example, all our PGs are happy doing a Wilms tumor. As them after 5 years, what happened? They don't know. 2 years, what happens? Nobody knows. They have insurance issues. They have second malignancy. They don't know. So I think we need to inculcate this long-term approach in our training, in our education, in our counseling mechanisms when our child comes. Start small, but start. Persist and brave setbacks, they're going to happen. Innovate and improvise, because Jugaad is what defines Indians. Spread awareness. In conclusion, I would like to say transition care is still now a nascent concept, but it's a pressing need. Very tough road ahead, but persist we must. And this is the emotional thing which I had put it earlier. Anyway, it talks about the daughter being sent away from the father. It exactly is that. Sasural mein itna pyar mile, tu mai ke bhul jaye. That's exactly what we want. In conclusion, I would like to say, this being a nascent chapter, a long way ahead, with a lot of resistance. Simple. हम होंगे कामयाब. हम होंगे कामयाब एक दिन. मन में है विश्वास, पूरा है विश्वास. हम होंगे कामयाब एक दिन. हम चलेंगे साथ साथ, डाल हाथों में हाथ. Thank you very much, ladies and gentlemen. I would like to end by just very special acknowledgements to Dr. Vipul Upadhyaya, who instilled the confidence in me, gave a lot of inputs. Dr. Saundar helped me through the journey in about these things to get the material, my patients, my institutions, institute, and my colleagues. Thank you very much, gentlemen. I hope this is useful. Am I audible?
Yes,
Yes,
sir. Yes.
No pin drop. I thought somebody is going to at least shout at me. Nobody. Thanks.
Okay. Okay. Thank you very much, Dr. Ramesh. It was an excellent talk, and many of the things which we were all in our thoughts, you have told us again. I think in the chat box, someone has mentioned, Dr. Sujay, I think, that sometimes it's difficult to even to make a OPD card after they cross 12 years. And same thing with, getting them admitted. It's always an issue, but recently I had to operate on a 21-year-old, a follow-up of bladder exstrophy with augmentation. He had stones and he was not getting any date from the urologist. So these problems keep occurring. So I think from what you have said, one is that we should all probably start off with some adolescent clinic where we are identifying patients who need further care. And then we should, as you said rightly, that you have to identify counterparts in other departments who are interested to treat these patients. So I had one child with for whom I had done an AVF, but she also required, she had some problem in the genital tract, some bifid uterus and no vagina. So she was having hematometra. I mean, she was having a lot of problems which were so the I had referred to the gynecologist because I thought she will need a lot of care later on also. But they said, please come to our OT. So that was one thing. They, even though I said it's only an AVF, I've done primary PSRP. There was another child again with a gynecological problem. They said, please, we'll do it in your OT. We'll come and do it there. So this is another thing. They're also worried. But as you said, we have to find a link, especially with some surgical colleagues. There are many things. One is whether we treat ourselves or we do the transition or we then give it straight away to adults. So probably the transition care, because the patients also have a lot of bond with us, especially parents. They'll say, nahi, aapko hi dikhayenge. And then you have to keep on telling them. So these are the problems which we all face. We are also attached to them, but we know that we have to give up and give it to someone else. Not all the patients, but some of them definitely need further care. So if there are any other, I can't see a lot of comments.
Can I have
Dr.
a,
Meera said that she wants to speak for a minute.
Can I have
Meera.
a-
Meera wants to speak.
Yeah,
Yeah.
please go
So
ahead.
my one word suggestion is, see, not all gynae people are like what Ramesh is saying, and they don't want. They all think they know much more about it than you do. So that's not always true. They think, what the hell are you doing? Even I was doing like a unicornuate uterus and with a hydrometocolpus, and they said, why? Literally, almost it went off all right. So, like you're talking about 12 years, Prema, the first thing is that all public hospitals should actually make your age to 18. In the private sector, the first thing they quote is that public hospitals are 12. Why are you making it 18? Now, IAP has clearly defined that a child is up to the age of 18 years. So, it will make life for all practicing pediatric surgeons if today AIMS and PGI says that we are increasing our age to 18. The first thing they will say, हमारे पास बेड ही नहीं है बड़े, हम आपको बेड रखने की जगह नहीं है, हम दे ही नहीं सकते. That will be the objection. But anyway, so coming back, I had my fight in one of the private hospitals, and then they made it so foolproof that 18 years and 1 day would go to the adult side, but 18 years minus 1 day would come to pediatric surgeons. The other hospital, I said, let me not have, when I joined another one, I said, let me not have this fight, do it another way. So I decided that I had a good relationship with the general surgeons. So there, like you said, even a 5-year-old anorectal malformation who was messed up, they sent to me. And in my fairness, if I'm doing a pancreatic surgery 1 in 20 years, I sent it to them. Because if they are doing so many pancreatic surgeries in a year and I'm doing one, I felt that they were better occupied. So I feel that instead of very black and white lines, if we are able to get their goodwill, like in adult cardiology, I don't know if you guys are aware, at least what I've seen in the private sector in Delhi, they do congenital anomalies, the person who does the pediatric. So very often their ward will be full of a VSD who's 50-year-old or 40-year-old, but is under the pediatric cardiac surgeon. And the pediatric cardiologist or the intensive care also looks after him. I don't know what is the views with other people.
Dr. Sareen has raised his hand. Yes, sir.
So this has already been mentioned, Meera, when we started that we all need to have children admitted to 18 years in every institution. I think I have actually half of the beds as I had in MAMC in Lady Harding, but still we will admit all patients up to 18 years. So there's no question on that. And agreed that most of us have kind of interacted with the adult people, physicians, surgeons, and all that. And we can talk about some anecdotal cases. But what needs to be done and what Ramesh has mentioned, I'm in UK as of now, and I've fixed an appointment with the Manchester NHS Trust Hospital. And I'm going there in 2 days to see their transitional care. So there also, when I call them up, I mean, they do it over 3 years. So basically, from 16 and a half years of age onwards to say 19 and a half years of age, all these young adults and adolescent children, they will be seen in a single clinic. I mean, the people from the pediatric surgery, pediatricians will come, and the physicians and the adult surgeons and adult urologists will come. So I think 20 years odd, we have been working on anecdotal cases. It has to be planned. It has to be sanctioned by the government, and it has to be done. Eventually, corporates will also take over. But this has to be done in a very planned way. It can't be just one-to-one, that I know somebody in gynae and give them a call and they do attend it. It has to be a system put in place where everybody who needs that kind of advantage should get the advantage. Eventually, I was even wondering, as Prema said, that probably even the young adults, I mean, if they need our expertise, why not? And vice versa. I mean, if I am tomorrow going to treat a patient of RCC, we not into immunotherapy. We do not. We of course we know how to do NSS because we started doing for WIMS, but so it has to be a planned activity. It has to be started in every institution. Sure, what I will work. The DG who was my friend is retired. The new DG is also from Lady Harding. And because the pediatricians have already come with the document and it is on the website of Ministry of Government, similar effort has been done by our chapter, this section of IAPS, and probably once few institutions in the capital and other national importance institutes will start, then it will slowly percolate to other state government hospitals also. The timeline could be another 5 years, so that doesn't matter. And eventually, in at least 10 years before we kind of wind up our practices and all that, it will be there in corporate and the private hospitals also. I'm very hopeful. It just needed a start. We'll achieve it eventually. Those who know me well, I'm quite a bulldozer. So in Delhi, I will definitely push it on. And the other bulldozers also, Shilpa is one in Delhi. So we guys will try to push it on. And I think we need the cooperation of all bigger institutes to kind of, start all this kind of, and slowly then you will hear it, other hospitals also taking over. Yeah, I'm very hopeful that it will work. But then we have to, I'm surprised on one thing, I was talking to a few younger pediatric surgeons, and I wanted to know what do they want to, like I was into reconstructive urology and oncology. I want to know what they want to do. They all said fetal surgery. I wonder, fetal surgery has not come up in a big way west. It came up and kind of dwindled. But people are not talking about adolescent surgery. It's a large segment of children which have not had the right attention all these many years. So there goes what Ramesh said, the training, you must inculcate in them very, very early. So probably if a short note is asked in their MCH exam in the coming years about adolescent surgery and transition care, they will start reading it. They will come to know what we're talking about. And by the time this whole process is crystallized, they will be there donning the seats that we don today, and they'll do a good job. I'm very, very hopeful. I'll never give up. And so let's go on with this.
Thank you, sir. Thank you, sir, for your comments. So I think we'll move on to the next talk. So maybe Shilpa will introduce.
So I would like to introduce the next speaker, Dr. Pavai Arunachalam. All of you know her. She's a very gentle and skilled pediatric surgeon, the professor and head of PSG Hospital, and she's recently been awarded with the Best Employee Award 2024 of PSG Hospital. Congratulations, ma'am. She has also been the president of the Society of Pediatric Urology. She'll be speaking to us on vaginoplasty, the pediatric surgical view, and the transition care. Ma'am, please make it full screen and you can begin.
Can you hear me now?
Yes, we can hear you, but your
just a
slide
minute.
Yeah.
Just a minute. Okay.
Yeah.
So first and foremost, let me thank all the organizers for giving me this opportunity to talk about vaginoplasty, because I think this is one field where really from antenatal till they get married and have their own children, we play a role. And the transition care is very, very important. So growing up whole, a pediatric surgical view on vaginoplasty and transition care. So first and foremost, let me say the timing of surgery depends on the presentation. So it can present in the neonatal period with hydrocolpos, in childhood with pseudo-incontinence, puberty with hematocolpos, adult with primary amenorrhea, uncorrected cloaca, UGS with hidden vagina, which is usually done as an elective procedure. Just a brief flowchart on neonatal hydrocolpos. As you can see, in cloaca, we do a colostomy, and if possible, we do a CIC through the cloacal channel or the UGS. Similarly, in UGS also, we try to do a CIC through UGS. In atresia with hydrocolpos, we do a vaginostomy or an abdominoperineal pull-through. Suppose in cloaca and UGS, CIC is not possible and there is hydrocolpos, again, tube vaginostomy or a modified Raffensperger, which I will talk to you about. So I'm just going to tell you some case scenarios which makes it easy to understand. So this is a baby with a neonatal hydrocolpos, either after UGS, with a UGS or a cloaca. It may not always need a vaginostomy. Just doing a simple catheterization might decompress your vagina and tide over the crisis, and later you can manage at puberty. In neonatal hydrocolpos, where you cannot catheterize or there is an atresia, we had two cases like this where they presented with an antenatal diagnosis of bilateral HUN with hydrocolpos. There was postnatal gross distension, palpable mass arising from the pelvis with mildly altered RFT, and ultrasound and CT confirm the diagnosis, and you can see these findings. So what did we do in this? In this, as you can see, we use the dilated vagina to create a tube which can be brought down to the perineum. And after that, this is your immediate postoperative appearance. And this is after a few months. We have done in 2 patients. And both are doing well. One does have a stenosis at the skin level, which we thought, anyhow, the baby does not have any hydrocolpos now. And we thought we'll tie it at puberty once the hormones start working. So in neonatal hydrocolpos without cloaca, CIC when possible, if not possible, tube vaginostomy, and then manage at puberty. We had another few cases where in childhood, they can present with urinary incontinence, especially in a cloaca after an anorectal pull-through. As you can see, what was happening actually was the child was voiding urine into the vagina, and this was causing the incontinence. In this, just using the dilated vagina to do a vaginoplasty cured the urinary incontinence. Coming to the third part, where they can present with primary amenorrhea and normal secondary sexual characters. An ultrasound will tell you whether there's a vaginal atresia with hematometras or hematocolpos. In that situation, you do an MRI, and that will tell you whether it's a low, an intermediate, or a high. In a low, with a hematometra or a hematocolpos, just a perineal approach will cure the condition. In an intermediate one, you can mobilize and bring it down, or if not possible, you can do a bowel interposition. In a high, always a bowel vaginoplasty is required. What happens when they do not have the hematometra or hematocolpus? They can have vaginal atresia with Mullerian agenesis. This can be managed in early childhood. If they have a vaginal dimple, you can do a dilatation. If it is not present, then they have to undergo a vaginoplasty. This we like to plan just before they get married. So some case scenarios, as you can see, at puberty, this child presented with hematocolpos, and you can see an MRI tells you it's a very low anomaly. And what happens here? Usual surgery which is done is a cruciate anastomosis, which needs dilatation and follow-up. Here, what we do is we take a U flap from the dilated vagina, take it anteriorly, then use this flap to take it back. So by this, you can see there's a nice adequate opening, and these children do not need any dilatation. And of course, they do come for follow-up, but they are doing very, very well. So in a low anomaly, you can do this. What happens in an intermediate? In an intermediate, an MRI or a scopy tells us whether it's an intermediate. And again, we do this only during puberty because we have seen the vaginal structures become better and you can handle it better instead of doing it in the newborn period. You can, again, we do not go very close to the bladder. Take care that we do not injure the UGS and just divide it obliquely, mobilize it and tubularize it and bring it down. And this is the cosmetic appearance after 6 months. This was another very interesting case, another cloaca who had a biconvate uterus. And here you can see we have mobilized the vagina and the uterus. But the interesting thing was what we have found is when you cannot bring it down because of the uterine vessels, you can actually ligate it. The ovarian vessels are sturdy and it allows you to bring it down. This is actually this girl is actually doing her medicine in Tirupati now. When high, of course, you have to do a bowel interposition vaginoplasty. So an MRI really clearly tells you whether it's a low, intermediate, or a high, and then you can manage it appropriately. This is just a brief diagram how we do it. We usually do a sigmoid vaginoplasty, and I don't know how clear these pictures are. As you can see, we take a part of the sigmoid colon based on the sigmoid vessels, but we bring the upper end down and and of course, create a space between the rectum and the bladder and bring it down. High, no vagina, what do? We have done few cases where we remove a core of the uterus and attach this bowel and bring it down. Why do we do this? Because what happens when there is cervical atresia, when you do a vaginal anastomosis and it is narrow, these children or these young people can go in for sepsis. So you have to make a very wide anastomosis by removing a core of the uterus from the posterior wall. And this is the vaginoplasty. And you can see it is very, very cosmetic. So let me talk to you about outcome. See, in our hospital, what happens is we work in a private hospital. Here, we can operate right from antenatal to even 50, 60 years. We can admit in our ward. We do have a good transition where the urologist, the gynecologist, the obstetrician, all of us play a team. It's like a team. So I can just call them, and the person, we have 1 or 2 people who are interested. They come and follow up these children. So we have had, I just could compile the data for 57, of which 32 are complete. UGS, we had 6, vaginal atresia 7, cloaca 18, imperforate hymen 4, others were 3. The cosmesis was satisfactory, as I have shown in few of my cases. 25 of them have attained menarche and their menses are regular. 2 have had stenosis and needed a revision in the perineum. Few of them have had dilatation, especially in the immediate postoperative period. Mucus discharge is not very troublesome, but when troublesome, what happens is we ask them to use a short course of antibiotics and if necessary, a vaginal douche. We have a mean follow-up of 5 years in this outcome group. 2 have committed suicide several years after successful repair, and they have been misdiagnosed as DST. So we have to look at the long-term psychosocial impacts in this group of children. Again, we did another close study of 25 when they had either a cloaca or a UGS. The outcome of vaginal reconstruction was satisfactory with relief of presenting symptoms in all. Regular painless menses in 18, others are prepubertal, widely patent vagina, new vagina in 23, and skin level stenosis in 2. But what is very, very interesting is all these children, 10 are on CIC through a Mitrofanoff channel, and all for either pre-existing congenital pathology, as all of you know, but urinary reconstruction or blood surgical mishaps. This has happened a lot after your total urogenital mobilization. So we have to be very, very careful when you do that. What do these children in the long-term follow-up, what has happened to them? Yes, they are having menses, but what we have had 4 patients in this group who have endometriosis, troublesome endometriosis. All these 4 children had a longer history before intervention. So when the hematometrocolpos has been present for a few years, what happens is they are more prone for endometriosis. So you have to counsel these children after you operate with cloaca, tell them they have to have a screening ultrasound around about 9 years, 10 years, and then have an abdominal ultrasound, if necessary MRI, before the onset of endometriosis. And 2 in a long term had to have a hysterectomy because of severe abdominal pain, not amenable for medication. 1 has a chocolate cyst, which is enlarging, but not very troublesome. So we're just following it up. This is 1 case of endometriosis. She was a cloaca. She presented at 14-year-old as a 14-year-old. Pull-through had been done, and she is on Mitrofanoff. Vaginoplasty had been done. She had a single kidney. Her creat was completely normal. Then she suddenly came with a rise in creatinine of 3.5. Then ultrasound showed the single kidney had moderate hydronephrosis. And then the endometriosis showed, the MRI showed uniform narrowing of the ureter because of endometriosis with chocolate cysts. So what we had done was a scopy, a stenting. Again, the adult urologist was there along with us, and the creatinine is completely normal. She's on a stent. We have a gynecologist who's interested in these children, and she has started them on medication, and now she's relatively symptom-free. But if she continues to have symptoms, we may have to do a hysterectomy. We have 7 children who are married with mulleriagenesis. 1 has a child, as you can see. And this is a very interesting story because she was a very young girl. Her mother was only 37. So they went in for an artificial insemination from the husband and the wife. And this is their own child, meaning genetically. 1 has dyspareunia, and 2 are planning for surrogacy. The question which we should ask ourselves after vaginoplasty, do they need an LSCS or a normal delivery? I think this question arises even after ASARP. A word about malignancy. A literature review shows bowel pull-through adenocarcinoma in 13 cases, and from 3 years after vaginoplasty up to 18 years. But there was another group who said the adenocarcinoma is similar to other population. But remember, these patients are more prone for adenocarcinoma. What causes this? Number 1, bacterial overgrowth, repeated infections. As all of us know, there is something called diversion colitis. When you take this colon and divert it from the stream, maybe that is causing that, we don't know. And HPV. So what they say is these children should have HPV prophylaxis. When you use skin, of course, they can have SEC. We have not used skin at all. So the protocol advised is the opening should be adequate. They should not be needing regular dilatation. They should have HPV prophylaxis. They should have a colposcopy and biopsy if necessary, at least after 2 years and every year. Coming to uterine transplantation. In patients with Mullerian agenesis, there is a lot of psychosocial problems. And only adoption or surrogacy was the only answer. Now 60 uterine transplants globally with 18 live births. And studies have shown that the promise of uterine transplant in patients diagnosed with MRKH has lessened the psychological distress of not bearing and delivering their own children. Only the future can show the feasibility of this procedure in India. Coming to the conclusion, management of UVA is challenging. It depends on the type of presentation, age, and associated anomalies. It should be undertaken only after thorough evaluation. We have a long-term interest in these patients until they get married and until they are symptom-free. And again, they have to be monitored if you use a bowel vaginoplasty. The timing and appropriate surgery should be performed. Oral pills can be used to suppress menstruation till the surgical plan is formulated. But remember, a dilated hematocolpos always aids in the surgery. Proper counseling should be done regarding sexual intercourse and follow-up. Long-term follow-up and QOL outcomes, I think we are really lacking in this. So unless all of us join together and see how our patients are, I really don't know how to talk more about this. Let me end this presentation, and I thank the organizers once more. We are having SPUCon 2025 at PSD hospitals. Please do come. Thank you.
Thank you, ma'am. That was an excellent talk. We have few questions on endometriosis. Dr. Sareen wants to know, does endometriosis indicate underlying vaginal stenosis?
Shilpa, definitely, I think so. But in our patients, what happens is they do have a normal menstrual outflow. We have seen for any stenosis, and that is not there. But you can never be sure because we have it's a very small number.
Regarding your patient having endometriosis and ureter stenosis, can you please explain that further? How did the endometriosis lead to a ureter getting narrow?
So basically, Shilpa, this patient is a cloaca. She's got a single kidney. She has undergone an anorectal pull-through, then an augmentation with a mitrofanoff. Then she had an absent vagina. She came a little late to us. So we have done a bowel vaginoplasty. She had the right hemiuterus with a chocolate cyst at that time. When she came to us, there was a very large chocolate cyst. And the left hemiuterus was very small without any endometrium. So we had to remove it. So we had done bowel interposition vaginoplasty. After that, she was completely all right for nearly 2 years. Suddenly, one day, she's from Chennai, basically. She landed up with a very high creatinine. And then we repeated the ultrasound. That ultrasound showed a large cystic mass in the right side. And because the creatinine was high, we did an RGP. Our urologist actually did it. He said there is something like retroperitoneal fibrosis. And our Dr. Devi, who's our gynecologist, both of them sat and talked together. And they said, this could be the endometriosis which is causing this problem. And then he stented it. After stenting it, she started her on medications. After that, the cyst started regressing because once you stop the menstruation, the endometriosis comes down. And the creatinine came down immediately. So that's the story.
So probably it was putting some pressure on the ureter.
Yes,
lower
yes,
end.
I think so. Yeah.
So ma'am, in my follow-up patients, I've had some patients of cloaca who have spontaneous abortion. Have you faced such a situation? Like they're not able to retain the fetus itself.
Yeah, I think it's because of the small uteri. So
and
even cervical incompetence. That is the other thing.
And secondly, some of them have uterus diadelphys. So they menstruate in 2 cycles. One cycle finish, and after 15 days, you have another cycle from the other side, landing up with even severe anemia due to menorrhagia. Have you seen that kind of a situation?
No, Shilpa, no. The numbers are not too many, as you can see. So
I had that in 3 patients. So now every patient that I see has a uterus diadelphys, I start looking for it. That she's also going to have a similar problem. They're even ready to go ahead with hysterectomy, do anything and stop this blood coming out so much. It was a very interesting talk, ma'am. Thank you so much. I hand over now back to the organizers and congratulate the first webinar for this new chapter. I congratulate all the chairpersons, Dr. Subhashis, Dr. Alpana, Dr. Sunita and their team. It was wonderful. Over to you for a conclusion.
So you want to say something, Subhashji sir?
Okay, you can conclude. You can ask Dr. Alba.
So today I am really feeling very honored to express my heartfelt thanks to all the remarkable seniors who inspired us all to take the complete treatment of a child even beyond the adolescent age group. And we have seen a long series by ma'am that what complication can happen in future, and we should be vigilant for this. Thank you, sir, for the pillars of strength and wisdom for us, and we give thanks to our chairpersons, our speakers, our moderator, our whole entire team of this new section, and most importantly, audience who joined. The VK sir didn't join because of some reason, but he behind the scene he helped a lot me to organize this section, this webinar. Thank you all for giving valuable time.
Sunita, if you permit me just a minute, because
Yes,
this
sir.
being an inaugural program, I wish to congratulate the entire section, because you've been tireless in hunting us down for a talk, presentation, etc. Subhashis for all the background activities, Dr. Sareen and Dr. Bora for their constant support and goading from behind, and Dr. Pavai for her excellent talk with a lot of practical insights. In fact, what I liked about her talk was just about saying something of. She backed her with good amount of literature with her practical experience. I think this is a brilliant start for the entire thing. I mean, the entire innings of our section. I only wish more people had joined. It doesn't matter. Whoever is there, like I kept saying, we will start, but start. Doesn't matter. We'll start. We'll persist. We'll win. Hum honge kamyab. Thank you.
It's recorded, so I think you can share the link and everybody will get to hear the wonderful talks.
Yeah, thank you everyone
Dr.
for joining.
Sareen wants to say something.
Just before
I was noticing the maximum number of people at one given time was 43. It's a good start, I suppose.
It went up to 47, sir, 1.47.
47, okay. And I must also congratulate Pavai to touch this topic of uterine transplant. Now it's done very frequently in a private setup in Pune. I had the opportunity to go and meet the surgeon, and he's very okay if anyone of you wish to go and join and see how uterine transplant. So the new armamentarium actually to the whole thing, which many patients of ours would eventually need in their young adulthood. Thank you so much.
Thank you.
Yeah, so thank you and good night, everyone.
Good night. Thank you.
Thank you, sir.
Good night. Thank you.
Stop.
Sunita.